Hello, this is Dr. Audrey Cook. I'd like to welcome you to the next installment of Cooking with Fluids. In this lesson, which is lesson number 5, we're going to be talking about how to monitor and adjust our fluid plans. So we're going to run through the information that we're going to use to make changes as things move forward. It's really important that we regularly go back and look at our patients and see where they're standing. And the reason for this is that our initial assessment of the hydration status was inevitably fraught with error. It was always going to be our best guesstimate. And things can change when patients are in the hospital. We might gather more information, we might see things differently. When I think about making a fluid plan, I think it's very much like setting sail in a small boat. You've charted your course and you've gone out to sea, but things can change. The tides can change, the winds can change, stuff can throw you off course, and you've got to keep looking at your compass. So you have to reassess, reassess, reassess. When I think about the monitoring tools that we have to assess our patients on fluid therapy, there's various things that we can reach for. Some of them are fairly subjective and others are a bit more objective. What's frustrating is that we can't always rely on just one, and we usually have to integrate all the information we have available and try and piece the whole story together. Body weight, in some ways, is one of the most useful parameters that we use to try and assess a patient's response to fluid therapy because it's a nice objective piece of data. What is important, though, is to set yourself up for success. And so to get a really reliable baseline weight. And what I mean when I say that is weigh the patient as it enters ICU with its IV catheter and its bandage wrap in place. Be sure to use the same scale each and every time you weigh the patient. And then take a piece of paper and do the mathematics. If you think a patient is 8% dehydrated, decide what that weight will be when you've hit your target. Now, for all that body weight is a factor we use routinely to assess our progress, there are some things that can be a little bit misleading. What you may be doing is actually weighing fluids that physiologically had left the body. And what I mean when I say that is if a patient's got, for example, a very full bladder, you're going to weigh that, but that fluid is no longer part of them. Similarly, a stomach full of fluid, you're weighing it, it's not part of the body anymore. Or intestines that are containing a liter or two of incipient diarrhea. Urine output, in many ways, is one of my major go-tos as far as trying to assess my fluid plan. And the first option is just a very, very simple, crude, yes, the animal has urinated versus no, he hasn't. One of the first things I do when I get a morning transfer case is take a look at the chart and see if the patient has urinated, because that information is so easily available and so useful. It's not a hard and fast rule, but certainly is a good guideline. If a patient's on an appropriate fluid plan and their hydration status is on the road to recovery, we'd expect that animal to have urinated within 6 to 8 hours of starting fluids. And if he or she hasn't, we have a problem. If you want to be significantly more sophisticated, we can actually quantify urine output, either by placing a urinary catheter or by weighing pee pads. And this information is extremely valuable because it tells us a lot about renal perfusion. You have to be sending enough blood to your kidneys to make urine, and so plenty of urine means adequate renal blood flow. Well, urine output will also tell us a little bit about renal function. Poor output in a patient on robust fluids is a really reliable marker of acute kidney injury. And the third advantage to quantifying urine output is that we get a heads up if the patient is having some kind of a diuresis. We sometimes see this in patients who've been obstructed or recovering from acute kidney injury. These patients can have truly copious urine output, which needs to be addressed. We do have some useful guidelines for trying to determine how much urine output is appropriate. It is really important that you stop and consider the patient's hydration status first, because that is going to have an influence. So these numbers are presuming that a patient is on an appropriate fluid plan and is not still aggressively volume conserving. We say a patient is anuric or has anuria if they're putting out less than half a mil per kilo per hour. We use the term oliguria if the patient's putting out half to 2 mils per kilo per hour. We say a patient is polyuric if they're putting out more than full mils per kilo per hour. So staying on the theme of things we can learn from urine, urine-specific gravity can also provide some really useful information about a patient's hydration status. Do have to bear in mind, though, that things other than hydration status can impact our USG findings. The first thing to consider, obviously, is renal disease. If the patient has renal dysfunction, they're not going to be able to concentrate their urine. Also got to think about the impact of solutes such as glucose. That's going to confuse our refractometer. Many patients with endocrinopathies are going to have dilute urine even if their kidney function is good. And then lots of medications like glucocorticoids and diuretics are also going to make the urine-specific gravity much less useful. If we assume, though, that we have a patient who does have normal renal function and doesn't have anything like an endocrinopathy that's going to confuse its ability to concentrate its urine, we can use our USG to get some idea about a patient's volume status. If the USG is over 1035, then that patient is volume conserving, and you may want to up your fluid planning. If the USG is 1025 to 1035, that's not ideal, but it's acceptable. I feel very good if a patient on fluids has a USG that's between 1015 and 1025. That makes me think this patient is essentially euvolemic. If the USG is less than 1015, the patient is either well replete or volume loaded. Measuring the resting respiratory rate is one of the very nice ways we can spot volume overload, particularly rapid volume overload, which essentially quickly overwhelms the ability of the heart to keep pumping against an increased afterload. The nice thing too is the patient doesn't have to be disturbed. It's extremely low tech. The technician just simply has to walk up to the cage and actually really should try and not disturb the animal and count the resting respiratory rate every 1 to 2 hours. As a rule of thumb, a 25 to 30% increase in the resting respiratory rate should be regarded as a red flag. And this is going to occur way before we hear anything abnormal listening to the patient. So it's actually much more useful to count the respiratory rate versus auscultate the chest. Lab work, unfortunately, doesn't give us much useful information about our patient's volume status and progress with fluid therapy. PCV and total protein might give us some guidelines, particularly if we look at trends rather than absolute values, but these can also be impacted by the patient's disease, and so that can really throw us off. It's very important to remember as well that electrolytes tell us nothing about volume status. So let's think about the signs that would make us suspicious that a patient might have volume overload. To my mind, at least, these are very dependent upon the rate at which the volume overload occurs. In patients who get acute volume overload, most of the signs that we're going to see reflect the fact that the heart has been overwhelmed. And so the things that go along with acute volume overload strongly reflect that. So we're going to see an increase in heart rate. We're going to see an increase in respiratory rate. Patients often appear to be restless and anxious, and sometimes they're overtly nauseous. The clinical signs that we see in patients with a more insidious volume overload are quite different. In these patients, the heart is still managing to pump, but the poor animal is simply having to put surplus salty water wherever it can. And so the skin becomes gelatinous. These animals can be overtly wobbly on physical exam. We'll also see chemosis, so swelling of the conjunctiva. A dripping nose is a classic sign of volume overload. If things get bad enough, these patients can actually have cavitary effusion, and they can certainly feel pretty depressed and uncomfortable. Anytime, anytime you suspect a patient is volume overloaded, the solution is very simple. You turn off the fluids. You do not turn them down. You do not equivocate. You hit the stop. So take-home messages from lesson 5, again, are pretty straightforward. It's tremendously important that we reassess our patients. We need to be doing that all the time, and then also be prepared to make adjustments. Things can change pretty fast.